I'll start. Hi, good morning everyone. So I'm going to be presenting a retrospective analysis of 15
We
cases
have 5 minutes.
of gasless vitrectomy with cutter-assisted ILM internal peeling, which I've called as the CAIP technique for macular hole repair. So we know idiopathic macular holes are complex vitro-macular interface disorders and a prevalence of 3.3 cases in every 1,000 individuals. Till date, we've been doing three things. We started off with PVD induction, which gave us a success of 50 to 60%. We went on to ILM peeling, which gave a success of around 80%. And then went to inverted ILM peeling, which has gone to 90%. And the two things that have stayed common is the post-op positioning and the gas tamponade. But the problem was, how do we reach 100% closure? We're still stuck at 90%. There is some failure rate that does happen. We did something different. So what we were doing is, conventionally we were using the cutter, we were using the steering the retina, and then we were peeling with the ILM forceps, and we were using the forceps to somehow cover the macular hole. So we're doing something different. So let me show you what we're doing. So we go ahead with a routine PVD reduction and a core vitrectomy.
Performing a 25 gauge vitrectomy, starting with a core vitrectomy followed by a posterior vitreous detachment and completing the vitrectomy up to the periphery. We perform a fluid gas exchange and inject brilliant blue dye for proper staining of the internal limiting membrane for up to 2 minutes. Using the Dhami's ILM peeling forceps designed by Epsilon, we scrape the ILM and obtain a temporal flap to a sizable amount, and with the help of the 25 gauge cutter, we trim the excessive ILM. Now what follows next is the CAIP technique. Herein we use the flat base of the 25 gauge cutter system by Alcon, and we just gently plug the ILM into the macular hole, and voila, the macular hole is opposed. We don't need any
we're not using any long-acting gas tamponades. We've been just using air for the last 15-20 cases where we've done. So our results have been pretty astounding. So we've had the macular hole ranging from small to large and a median diameter of 968 microns. What was actually amazing was that the ELM and EZ restoration was noted in about 33%, and a post-operative visual acuity improvement was seen in 66.7%. And the best part was there was 100% macular hole closure. We were not using any tamponades and no gas position, no positioning post-operatively. These are some of our results. So if you see on the image on the left, you can see these large big macular holes, and on the image on the right, you can see a well-opposed macular hole with no post-op positioning or any mount. So in conclusion, the CAIP technique definitely demonstrates a significant promise as an advanced approach for treatment of large macular holes. The CAIP technique allowed us to achieve 100% lateral closure for macular holes more than 500 macrons, and the best part was we were not using any gas tamponade or any post-op positioning. Thank you.
So it was just you left the IFR.
Yes, sir. That's it. Yeah. Just to FG and we left it.
Okay.
What was the maximum hole size?
Yes, ma'am.
What was the maximum hole size?
1300 microns. 1300 microns.
1300 at the base.
Yes, ma'am.
And what about, like you said that 100%, so how many were the number N? What was your N?
Ma'am, 15 eyes. At this point, we're doing 15 eyes only.
15 eyes?
Yes, ma'am.
And you compared it? Was there a comparative study?
No, ma'am. We're doing it now.
So there's no p-value or no study as such?
No, NASA.
This is just
first line case.
Like a pilot data?
Yes, ma'am.
But there's no actual statistics you've shown?
No, ma'am. None at this present. We're comparing it now with our older cases. And how much we have about, right now we have about 45 eyes in the other group.
You are not given comparative data?
No, ma'am,
and
not
you
yet.
not compared or how will you clear the confounding factors? For example, the surgeon factor.
Ma'am, only one surgeon, so that's what was the one factor that was there. I am trying to compare it with my older data, my last 2 years, but I wanted to have some more cases in this data because that was the higher number. So the statistics was not falling in coherence.
So this was only 15 cases.
15 cases, sir.
These were only 15 cases.
Yes, last 15
And
cases.
a maximum size was 1700.
1300 microns, sir.
Maximum size.
Maximum size at this point.
And minimum?
Sir, 800.
800 to 1300.
Yes, sir.
Okay, good. Visual acuity results?
So we had, on Snellen's chart, the patient was on 660, we've gone up to 680 and 612.
That's good. Thank you.
Thank you, sir.